Thank you very much for inviting me to speak at this lunchtime symposium. I particularly want to thank Nestle and also acknowledge the other companies that have supported my research over previous years. So what we're going to talk about today is protein needs and protein delivery and difficulties with protein delivery during ICU stay, during critical illness. So I thought I'd start by referring to the most recently published guidelines on nutrition provision in critical illness. And they are the American guidelines published by the American Society for Parenteral and Enteral Nutrition. And they were published in February last year, so they're quite recent. And what they say about protein administration in ICU is that, well, they're suggesting a high dose. 1.2 to 2 grams per kilo of actual body weight per day, and even higher in patients with burns and multi-trauma. And this is quite high when you consider that the usual intake of protein in health is around 0.7 grams per kilogram per day. And particularly high when you consider that the usual administration of protein in ICU currently is about 0.5 to 0.8 grams per kilogram per day. So it's a very high dose, a big change in practice. You would hope that this recommendation is based on substantial evidence, but in fact, disappointingly, the quality of evidence supporting this suggestion is at the moment very low. So just to look at this, essentially the recommendation was based on a couple of observational studies. So this is one of them that I'd just like to take you through. This is a study published by Peter Weiss and his group in Critical Care in 2014. So as I said, it's just an observational study. They looked at about 800 patients coming through their ICU. They divided those 800 patients, they were mixed patients, they divided them into septic and non-septic patients, and then they further divided them into patients who received more than recommended calorie intake or less. And then they further divided them into 4 groups of protein intake. And what they finally found after all that subgroup division was that patients who received more than 1.2 grams of protein per kilogram per day, if they were not septic and not overfed, they had an improved survival. So this is promising data, but I would regard it as hypothesis generating rather than really robust evidence on which to base a guideline. So I just now want to show you some work that Michael Davies did at our centre. So Michael Davies is one of our senior trainees, and he did this for his research project for his fellowship. So this is a meta-analysis of all the studies that he could find looking at protein intake and survival in ICU patients. So what he did here was he looked for studies where there was a difference. Patients were randomized to a different nutritional strategy that resulted in a difference in protein intake, and then studies where mortality was reported. So I want to emphasize here that a lot of these studies were not done specifically to look at protein intake. It was just that the nutritional strategy resulted in a difference in protein delivery. And what you can see here is that there was quite conflicting results from this group of studies. So for example, here's a study which suggested that high protein was associated with improved survival. And here, there are a couple of studies which show that high protein was associated with harm. But nevertheless, overall, there was no difference, no effect of protein delivery on survival. We'll just look at the results in a little bit more detail. Firstly, just to point out that there was a lot of heterogeneity in the studies, and a lot of the studies were not robust. They were small in number and poor methodologically, but nevertheless, no signal of any benefit or harm from protein. Now, I wouldn't regard that as the final answer because there are still a lot of improvements to be made on the research around this topic. I'd just like to focus on one particular study that Michael included in that meta-analysis. So this is a study done by Susie Ferry, published in JPEN in 2015. She's a dietitian from Sydney. And what she did was she randomised 120 mixed ICU patients who were receiving TPN, so this is intravenous feeding, not enteral, So randomise them to 0.8 or 1.2 grams per kilogram per day of protein. So it is easier to modify protein delivery using intravenous feeding. So it's a small study. There were 60 patients in each group, but she did have some quite promising results. So hand grip at day 7 was greater in the high protein group, as was measures of muscle bulk or muscle thickness. So she measured that with ultrasound. And there was an improved fatigue score, so less fatigue in the high protein group. The hand grip difference was gone on ICU discharge. So as I say, this is a small study. The benefits were small, but they were measurable, and I think this needs to be further investigated. So the take-home message with regards to protein needs for critically ill patients is that there is a current interest in delivery of high protein dose. And the current recommendations suggest 1.2 to 2 grams per kilogram per day, which is a lot higher than current standard practice. I think we all need to be aware, if we're trying to deliver that the quality of the evidence at the moment is poor, and so to keep an eye on the literature for changes in that message. But one of the big questions you should be thinking about when you're trying to deliver nutrition in general, but particularly protein to your ICU patients, is can the critically ill gut handle that protein? Now, this is based on the premise that we should feed all our patients enterally, so the evidence for that is strong, and I'll be covering that in another presentation tomorrow. So if we look at usual feeding practices around the world, and we've got really good data to look at this. So Darren Hyland does a regular international nutrition survey. So he's got data from thousands of patients around the world, from hundreds of centres. And what he's found from these surveys is that most clinicians aim for what we call eukaloric feeding. So this is based on recommended requirements as per the guidelines, the published guidelines. So something like 25 kilocalories per kilogram per day, around about 2,000 calories for the average adult. But then what happens is that usual practice only delivers around about 50 to 70% of that prescribed intake. So if you prescribe 2,000 calories a day to your patients, usually your patients are only receiving around about 1,200 to 1,500 calories a day. That's been shown repeatedly in different observational studies over the years. So it's a very widespread practice. And when we look at the reasons why feeding is not delivered, why feeding is stopped or slowed during ICU delivery, and we did a study on this some years ago now, the most common reason is gastrointestinal disturbance, and that's most commonly manifest or picked up by a large gastric residual volume. Other reasons for stopping or slowing feeds are for airway procedures such as planned extubation or tracheostomy, and other surgical procedures or radiological procedures, and then just other factors like feeds running out, feeds not available, or involvement in studies. So I just wanted to show you some observational data that we've collected from our site. This is unpublished data. This is looking at the incidence and occurrence of feed intolerance in ICU patients. So we just collected observational data on over 350 consecutive mechanically ventilated enterally fed patients, and we found that the incidence of feed intolerance was 35%. So 1 in 3 patients had feed intolerance, and in our unit that's defined as a single gastric residual volume of greater than 250 mils. But the other interesting thing about these data is that the feed intolerance tended to happen very early on in the patient's ICU stay. So from day 1 to 3, the patients were developing feed intolerance, and then subsequently that all settled down and feeding became a bit more straightforward. Now I just want to go through the gut dysfunction which underlies our difficulties with enteral feeding. So firstly, to talk about gastric emptying. So we have measured gastric emptying. We do measure gastric emptying in our ICU patients for research purposes. You can see why it's only for research purposes when you see this slide. So this is a scintigraphic camera. So scintigraphy is one of the most accurate ways of measuring gastric emptying. And what this involves is placing a marker. So we mix a radioactive marker with our standard feed and put it into the stomach. And then we watch it empty over the subsequent 4 hours with this camera. Now I just want to show you a video of the sort of data that we collect from this camera. So this video was given to me by Palash Kar, who did some of our gastric emptying studies in our site. So hopefully this works. Yeah, there we go. So sorry, I have to go back. So this is gastric emptying in that's actually in an ICU patient, so that's very slow. So what we can see here is what we call the area of interest. So that's the stomach. And we've condensed the period of time. So this is over a 4-hour period. We've condensed it down to just a couple of seconds. And if I can play it again. So that's a healthy patient. And you can see there that there's very rapid emptying out of the stomach and into the small intestine. And this is the ICU patient where you can see that there is very slow emptying. At the end of the 4-hour period, there is still residual marker left in the stomach, so incomplete emptying even over 4 hours. So I'll just skip over those slides. So I've just got some group data to show you now from gastric emptying studies. So this again is scintigraphic data. So what we're looking at here is the percentage retention of the marker at the end of the 4-hour period. So 100 mils of labelled feed has been put into the stomach, and what we're looking at here is what's left in the stomach at the end of the 4-hour period. Now, in healthy people, that should be 0. In fact, in a healthy subject, they should have completely emptied by about 90 minutes to 2 hours. But you can see here, in this population of ICU patients, there's 25 ICU patients here, and about 50% of them still have residual marker left in the stomach at the end of the 4-hour period. But of more note is that about 20% of them have more than 50% of the marker left in the stomach at the end of the 4-hour period. So this is markedly delayed gastric emptying, and this is a big problem in our ICU patients and a big problem for our ability to feed. So you can see here that in the healthy subjects, there's nothing left in the stomach at the end of that period. So if we just look at the problems with motility that we see in our patients in the ICU, so the stomach can be functionally divided into proximal and distal sections. So the proximal stomach is involved, so normally what happens in the proximal stomach as we eat is that the proximal stomach relaxes and then acts as a reservoir, so it stores the nutrient, and then it delivers the nutrient in a controlled fashion into the antrum of the stomach, so that can then empty in a controlled fashion into the duodenum. In the ICU patients, there's less relaxation of the proximal stomach, there is fewer contractions, and it's slower to regain tone, but there's also less coordination, so there should be a nice coordinated peristaltic activity between the proximal and distal stomach, and that's not happening in the ICU patients. So it's discoordinated and they're not functioning well together. But the most characteristic abnormality and critical illness in the stomach is in the distal stomach. The antrum is particularly immobile, so it just becomes flaccid, it stops contracting. Again, there's poor coordination, so there should be nice coordinated peristaltic activity between the distal stomach through the pylorus into the duodenum. That's not happening. It becomes very discoordinated. And this all occurs because of a heightened small intestinal feedback. So the normal control of gastric emptying in health is that as you get movement of nutrient into the small intestine, that stimulates the small intestinal mucosal receptors, and that feeds back on the stomach to slow emptying and really precisely control gastric emptying at around about 2 kilocalories per minute. So, but this feedback response in ICU patients is exaggerated So just a little bit of nutrient moving into the small intestine will feed back on the stomach and slow gastric emptying. And this reflex appears to be quite strong. So it feeds back to reduce antral activity, but it also increases pyloric activity. So increased tone and increased contraction means that the pylorus is completely closed and obstructing flow. So as I said, we get feedback on all aspects of the stomach from mucosal receptors in the small intestine, but this feedback is exaggerated in ICU patients. So this is just showing those data in a different way. So this is manometric data. So this is pressure waves measured in the stomach, in the antrum of the stomach, the pylorus and the duodenum. And so this is in a healthy subject up the top here and an ICU patient down the bottom. So up the top we see a sort of normal pattern, intermittent contraction throughout the stomach, pylorus and duodenum. And I think you get the impression here that there might be a nice antigrade propagated wave moving down from the pylorus into the duodenum. So if you compare this to an ICU patient, here we got the antrum, it's completely immobile, there's no antral contractility at all. Then the pylorus is contracting rapidly, and what you can't see on this graph is increased pyloric tone. So the pylorus is essentially closed with a flaccid antrum. The duodenum appears to be contracting fairly normally, but if you look carefully here, you get the impression that there's a retrograde peristaltic wave, so pushing nutrient back up into the stomach. And we've quantified that activity, and that certainly is occurring much more in ICU patients than in health. So then it's interesting to consider what is mediating all this abnormal activity in the stomach and the small intestine. And one of the potential culprits is hormones. There's a number of gastrointestinal hormones. The most promising of these is cholecystokinin. So we all know cholecystokinin as being a hormone which mediates gallbladder contraction, but it's also a very important mechanism or hormonal control for stomach activity, and it's believed to be one of the most important hormones for that feedback response that normally controls gastric emptying. So Nam Nguyen in our site did some studies looking at cholecystokinin concentrations in our ICU patients. And so this is a group of ICU patients compared to healthy subjects, looking at CCK levels during fasting. And CCK was markedly elevated during fasting in the ICU patients. But what's really interesting in these data is the response in the ICU patients to the infusion of nutrient into the small intestine. So the increment in CCK there was markedly exaggerated compared to the increment in health. And then we divided the ICU patients into those who had previously been tolerating and not tolerating their feeds. And again, the CCK levels were markedly elevated in patients who were feed intolerant, so had large gastric residual volumes, slow gastric emptying. And again, the increment in response to small intestinal nutrient was markedly exaggerated in the feed intolerant ICU patients. So this suggests that CCK may be the mediator for this abnormal gastric function. It also makes CCK a very logical and attractive therapeutic opportunity to block CCK activity. There are CCK antagonists, and we haven't yet been able to access one to do a study to see if that's going to help with our patients with slow gastric emptying. That's something we still plan to do. So it's probably helpful to consider what are the clinical things that can influence the rate of gastric emptying in ICU patients. And there's several things that we know influence the rate of gastric emptying in health and in other patient groups. So firstly, patient position. So if the patient is sitting up or if the patient's rolled over slightly to their right-hand side, then gastric emptying will be accelerated. So age and sex affect gastric emptying rates. So gastric emptying tends to be slower if you're older and if you're female. I think it's well known that certain medications, particularly medications that we use in ICU, will slow gastric emptying, so opiates and catecholamines. Diagnosis, I'll talk more about in a minute, and calorie density, I'll show you some data that we've got on that. So the osmolality of formula is also important, so increasing osmolality slows gastric emptying. And I'll also talk about the possibility that the presence and type of protein may influence gastric emptying. So firstly, let's just look at some of the data we've got on the relationship between admission diagnosis and slow gastric emptying. So again, this is some work done by Nam Nguyen. So he collected all the patients, all the data from the patients who'd had gastric emptying measured in our unit. And as I said before, around about 50 to 60% of patients in a general ICU population have measurably slow gastric emptying. But when you look at the individual diagnostic groups, there's certain groups that are at high risk of having slow gastric emptying, and they are burns, multi-trauma, head trauma, and sepsis. And then when you compare those groups to others, such as post-op non-GI surgical patients or cardiac patients, then those have a lesser risk of slow gastric emptying. So you can identify patient groups who are at risk, are more at risk of slow emptying, and so problems with their feeding. So the other thing that can potentially influence gastric emptying rate is calorie density. And so I want to show you this study, which was done by Palash Kar. So he got two different groups of patients. One group was given 1 kilocal per mil feed, which is a standard feed, and the other group was given 2 kilocal per mil feed, and we looked at gastric emptying rate in those two groups. So just to remind you, this is scintigraphic data. So we put the marker in the stomach at time 0, and we watch the emptying of the marker out of the stomach over a 4-hour period. So in health, that would be down to 0. Certainly by the end of the 4-hour period, but these are ICU patients, so they've got slow gastric emptying. So that's with 1 kilocal per mil. This is with 2 kilocals per mil, and so what you can see here is that there is slower emptying, so the volume of feed that's emptying out of the stomach over time is emptying a lot slower. But it's not really volume that we need to be concerned about. When we're considering this, we're actually more interested in calorie delivery to the small intestine. And given that the calorie density was higher in the 2 cal feed, the calorie delivery, even though the volume is being emptied more slowly, the calorie delivery to the small intestine is the same. Now, these data are very relevant because what has become common practice is that if patients have a high gastric residual volume suggesting slow gastric emptying, some practitioners, clinicians, dietitians will respond to that by changing the patient to, say, 2 cal feed, change them from 1 cal to 2 cal feed, thinking that they're going to improve calorie delivery and improve nutritional status. But you can see that these data don't support that practice. So you're not going to increase calorie delivery to your patients by giving them 2 cal feed. So what about the type of macronutrient that's in the formula? Does that influence gastric emptying? Well, this is a really interesting topic because we have previously thought that high lipid and high protein formulae are likely to be emptied slowly from the stomach. But in fact, that's not supported by this fairly recent study using a fairly new technique using MRI for the measurement of gastric emptying. So this group use MRI. So what they've done in this study is that they've given 3 different types of nutrient, lipid, carbohydrate, and protein. That's the same volume and the same amount of calories in each study. This is done in healthy volunteers. And what we're seeing here is the MRI data of the feed volume in the stomach over time and the total volume in the stomach, which includes gastric secretion, so additional fluid, and also air. And so what you can see here, here's the lipid, carbohydrate, and protein. It's actually the lipid which is being emptied the most rapidly. So that's at odds with our previous understanding of gastric emptying. so probably needs a bit more work, but it's possible that lipid actually isn't as emptied as slowly as we previously thought. So it looks like protein the presence of protein is not going to influence gastric emptying too much. So what about the type of protein? Well, this is actually a study done by the same group. So it's using MRI again as a technique for measuring gastric emptying. And what they're looking at here is different types of protein. So there's two different substrates which are used for protein, commonly used for proteins in feed formulae. So it's casein-based and whey-based. Now, the casein-based formulae tend to coagulate. So this is actually in a plastic tube. So this is in vitro, but it's simulating what happens in the stomach. So these are three commercially available formulae. B and C contain casein, and you can see how they coagulate in the plastic container. And this is a whey-based protein, sorry, whey-based formula. And you can see how that does not coagulate. And when you look at the gastric emptying of these three formulae, so this is a study, as I said, done by MRI. It's a double-blind, randomised, three-way crossover study done in healthy volunteers. So we need to be careful when considering extrapolating this sort of data into the ICU population, but nevertheless, this hasn't been done in the ICU population, so we need to use these data with a bit of interpretation. And what they found was that the non-coagulating formula emptied the fastest of those three. So it's all very well to talk about these, the pathogenesis and the pathophysiology of gut function, but what do we do actually at the bedside? How do we manage these patients? So we're obviously trying to feed our patients with a nasogastric tube. We're infusing nutrient, which we're hoping is going to be emptied from the stomach through the pylorus into the duodenum. But quite often, as I've shown you, we've got slow gastric emptying, and that results in large gastric residual volumes. Now, the management of large gastric residual volumes has become somewhat controversial of late, and that controversy is addressed in the American guidelines for management of nutrition in ICU patients that I started the talk with. So essentially, the issue is that there's two potential sequelae, clinical sequelae, from having a large gastric residual volume. So one is pulmonary aspiration. So people are afraid that as you fill up the stomach and the stomach's not emptying, you're putting the patient at risk of reflux, regurgitation, and aspiration. And the other is that the slow gastric emptying is going to result in reduced flow of nutrient into the small intestine, and so then have reduced nutrient absorption, and that will have nutritional ramifications for the patient, so poor nutritional outcomes. So the relationship between gastric residual volume and aspiration has been investigated or studied in 6 randomised controlled trials. And they've been summarised by Kuppinger and his group here in this narrative review. So this group concluded their review by saying that the data from these studies was not rigorous enough for a formal systematic review because the studies were too small, they were unblinded, really only 2 of them were of reasonable quality. But nevertheless, the underlying or the summary, the conclusion of all these trials is that gastric residual volume is not related to the risk of aspiration. And so the guidelines have then taken this and have recommended that we either don't measure gastric residual volume at all, or maybe only measure it once a day, or don't react to a gastric residual volume until it's as high as, say, 500 mils. But that's because they feel that there isn't any relationship between aspiration and gastric residual volume. What's happening there is that our patients are probably aspirating all the time. So there's a recent study where they looked at pepsinogen levels in tracheal aspirates and found pepsinogen in about 50% of aspirates. So our patients are micro-aspirating all the time, and it doesn't seem to matter what the volume of the stomach is. But my concern still is that is the other arm of the sequelae is that if you don't act on a large gastric residual volume, then you will lose the opportunity to improve the nutritional outcomes of your patients. So I agree with the American guidelines that you shouldn't stop feeding, but I would suggest that you do take measures to improve gastric emptying, which I'll talk about in a minute. So the response to a large gastric residual volume could be to do some simple measures to try and improve gastric emptying. So you could sit your patient up. You could, if possible, limit opiates and catecholamines. That's not always possible, but it will help. And you could consider changing to a feed formula that might be emptied a little more easily. And then what we tend to do is administer prokinetic agents. So we've done studies on prokinetic agents at our site, and our preferred combination is erythromycin and metoclopramide. So that's what we give first up with the first gastric residual volume of greater than 250 mils. So we still measure gastric residual volume every 6 hours, but what you don't need to do is stop or slow the feeding rate. If gastric residual volume continues to be large despite prokinetics, you can consider a small intestinal feeding tube. Okay, so I've talked a lot about gastric emptying and slow gastric emptying, critical illness, but there are other parts of the gut that can be affected by critical illness, and the other issue that can occur is that you can get nutrient malabsorption. So I just want to spend the last part of this talk talking about that aspect of gut function. So we have measured glucose absorption in ICU patients. We do this using a technique using a synthetic sugar. It's called 3-O-methyl-glucopyranose. So that is absorbed in the same way as glucose from the gut, but it's not taken up by the liver or muscle. So the blood concentrations reflect absorption and also later on renal excretion. So this is a study we did, an early study we did looking at glucose absorption using this technique. So here we place the glucose with some feed into the stomach. And this is in ICU patients versus healthy subjects. And you can see that there is a marked difference. So there's a marked reduction in both the rate and extent of glucose absorption in the ICU patients. But this is after we've put it into the stomach. So it's quite likely that this is just related to slow gastric emptying. So then what we did, in fact, what Anna Di Bartolomeo did, she was one of our honours students, was she put the glucose directly into the small intestine, because what we wanted to see was whether the small intestine was also dysfunctional. So here we've got, again, healthy subjects and ICU patients, and this time the difference is not as great, but we've still got significant reduction in glucose absorption. So we've got small intestinal mucosal dysfunction affecting nutrient absorption. And what Anna also did with these data was she divided the ICU patients into those who were previously feed tolerant and feed intolerant. So that is defined by a large gastric residual volume. So those are patients who've got stomach dysfunction, slow gastric emptying. And when we looked at those patients, the ones who had stomach dysfunction also had small intestinal mucosal dysfunction with reduced absorption of sugar. So sugar is probably the easiest macronutrient for us to measure the absorption of, but we have looked a little bit at lipid absorption. This is some work done by Yasmin Ali Abdelhamid. So she looked at lipid absorption using a labelled trilene technique. And you can see here, so healthy subjects, ICU patients, again, marked reduction in lipid absorption. So this is administered into the small intestine. So qualitatively, it looks like lipid is more severely affected than glucose. And we haven't yet started. We're planning to start looking at protein handling and protein absorption of the gut. But this is some data from a group in Sweden. So this is very small numbers of healthy subjects and ICU patients. But again, as with the other macronutrients, you can see that there's marked reduction in absorption. So just like to briefly go through the possible mechanisms for malabsorption in critical illness. Firstly, it could be related to abnormal blood flow. So we've previously thought that gut blood flow in ICU patients is reduced. But this is a study which was done by Jen Sim, one of our honours students, published in 2013. So she looked at gut blood flow with an ultrasound technique. So she looked at flow through the superior mesenteric artery. So here is healthy subjects and ICU patients. And we were very surprised at first to see that at baseline, so during fasting, in fact, the ICU patients had slightly higher gut blood flow. We weren't expecting that. Probably relates to the high cardiac output that these patients have. But what was important was that the increment in blood flow, so you normally get an increase in gut blood flow in response to the presence of nutrient in the gut, and that's possibly important for normal nutrient absorption. So this is the increment in health, but the increment in the critically ill patients was reduced. So that may be one of the reasons why we get impaired absorption. So here we're looking at the relationship between the change in blood flow in response to nutrient and glucose absorption, and you can see that there is a relationship between the two. So that was again from Jen Sim's work. So another possible cause for abnormal glucose absorption is that there may be an abnormality in glucose transporters. So these are molecular requirements for glucose absorption from the small intestine. So this is a study done by Adam Dane and Richard Young primarily in our centre, so this is a endoscopic biopsy technique where they took mucosal biopsies. They did it in mice and in humans. And so looking at the glucose transporters in healthy subjects and in ICU patients, you can see that the ICU patients and the sick mice all had reduced glucose transporters compared to health. And finally, pancreatic function is also required. Normal pancreatic function is also required for normal nutrient absorption. So this is a study done by Tribble and his group, published in 2003, where they looked at the concentration of pancreatic enzymes in duodenal fluid after stimulation with cholecystokinin and secretin. So these are controls, healthy controls, patients with sepsis and patients with septic shock. And you can see that there is a progressive reduction in the concentration of all the pancreatic enzymes. So this is yet another possible cause for abnormal absorption during critical illness. So you can see from all of these that it's likely that the underlying pathology is multifactorial. So again, trying to tie this back to what we do at the bedside, and this is actually an ongoing frustration for me, is how we can measure absorption of nutrient in our patients at the bedside, because we're often worrying, putting the feed into the nasogastric tube, but the patient perhaps has got a lot of diarrhea or they might have severe pancreatitis. They appear to be wasting over time. Are they actually absorbing what we're giving them? And it's really hard to identify that. So I just wanted to show you this one study published in 2011 where they looked at the relationship between nutrient absorption and fecal volume or fecal weight. So they found that about 1/5 of stable ICU patients were poorly absorbing their nutrition, but there was a relationship between fecal output and malabsorption. So that's perhaps a clinical clue that the patients are not absorbing. And is there anything we can do to improve absorption? So I'm talking about this as a separate issue from gastric emptying. Well, there's a few things that we can consider. Firstly, we should remember to feed our patients enterally and early. And this is some data from Nam Nguyen from our site, where he randomised patients to starting feeding on day 0 or day 4 and measured glucose absorption on day 4. And he found that the fasting period resulted in reduced glucose absorption. So suggesting that a 4-day fasting period is enough to impair subsequent small intestinal mucosal function. So supporting the idea that we should feed our patients enterally at least a little bit if possible. Now, another consideration is whether providing elemental or semi-elemental feeds may improve absorption. And really, this is an area of, that requires further investigation. But there are some data in populations other than the intensive care population. So this is a study done in elderly men where they looked at the ingestion of protein hydrolysate. So that's protein broken down into its amino acids versus intact protein. And they found that the protein hydrolysate did result in higher amino acid concentrations in the blood, so appeared to be better absorbed. And also importantly, that there was greater muscle accretion of amino acids with the hydrolysated form of the protein. So as I say, you've got to interpret these data carefully because it's not in the ICU population. I always think we should repeat these studies in the ICU population before we wholeheartedly adopt them. But prior to that happening, it's worthy of consideration. And finally, there's another formulation of protein which may be better absorbed, and so that's Waybased instead of casein-based formulation. We've already talked about the effect of that on gastric emptying, but this is a study specifically looking at amino acid absorption with those two types of protein. So this is a study done from Luc van Loon and his group, and what they've done is look at amino acid absorption using Waybased, casein-based and hydrolysated casein-based formulae, and found that overall amino acid absorption is greatest with the Waybased formulation, but it's not across the board because looking at phenylalanine, that is actually increased, absorption's increased with the hydrolysated casein. But most importantly is the muscle accretion. That's what we're trying to do when we give protein, is get it into the muscle, maintain or improve muscle bulk. And the Waybased protein was associated with improved amino acid accretion into the muscle in that particular study. Having said all that, the American guidelines are still suggesting that the standard polymeric formula should be used for most circumstances in the ICU, but I think those other formulae can be considered if you really feel that you're struggling with nutrient absorption. So I'd like to conclude by saying, or summarise by saying that at the moment, the optimal protein dose for optimal outcomes during critical illness is uncertain. The guidelines recommend high protein delivery, 1.2 to 2 grams per kilogram per day. But as I've shown you, the evidence for that is somewhat weak. Nutrition should be provided by the enteral route if at all possible, and I can go through the data to support that more tomorrow. The gut is disordered in critical illness, frequently disordered, and this may impair nutrition absorption. Gastric emptying is slow, and the small intestine is also dysfunctional, and that affects absorption. We should always remember that the dose of nutrition that you prescribe is not the same as what's delivered, and also, I think I've shown you today, it's also not the same as what is absorbed. And also, you could consider extrapolating those studies in elderly men where they delivered hydrolyzed whey protein to improve amino acid absorption and muscle uptake. As you can see, as I hope you can see after this talk too, there's a lot of research that needs to be done. Protein is a more difficult macronutrient to study, certainly than glucose and also than lipid, but we do need to better understand how protein is handled by the critically ill gut, what happens with protein absorption, and how to improve on protein absorption, so types of protein dose. But what's particularly important in all of this research is what outcomes we look at. And this is something that a lot of people are grappling with in the intensive care literature, because mortality is a very blunt tool. If you consider nutrition, either protein dose or calorie dose, it's not really likely to have have a marked impact on survival. But what it is likely to impact is functional recovery. But how we actually measure that, how we quantify that for studies is still uncertain. So that's probably the first step in this research program. So that's all I've got to say. Thank you very much. I'm happy for questions.
Lots of questions here.
Oh, good.
Just to summarize a few, should I let you get a drink first before
right.
I start going into it? Question on protein dosing, really. What is your opinion on the dose of proteins for patients in specialized groups of patients, like patients in ARDS, liver cirrhosis, and bariatric surgery patients?
Okay. So, so with regards to protein dose in ARDS, so there's no evidence that ARDS patients are any different from the general group, so I wouldn't be giving them more or less. I suppose the only relevant study there is the Eden study, which suggested that underfeeding that group is safe, at least in the first week of their ICU stay. That's not specifically about protein, so, but it suggests that perhaps neither protein nor calories matter too much in that particular group. So liver dysfunction. So there used to be a thought that we should give different amino acids to patients with liver dysfunction, but that's no longer practiced or adopted. There isn't really a lot of strong evidence for that. So both in renal failure and in hepatic failure, we tend to use standard feeds. And with regards to bariatric surgery, or perhaps more so to the obese ICU patient, which is a particular patient group of interest, because we do feel that it's very important to feed those patients and not let their muscles waste away during their ICU stay. So there's a general feeling that obese patients should receive high protein, low calorie feeds. Again, there's not a lot of strong data to support that. So that is a general sort of consensus view, similar to the guideline view about high dose protein. So a lot of dietitians, a lot of clinicians will be practicing that at the moment, but it really needs a little bit more research to confirm that that is beneficial.
Okay, thank you. Question on bolus feeding versus continuous feeding and its effects on gut motility.
Yeah. So, so there is an interest in bolus feeding amongst clinicians, and I understand there's a study going on in the UK to look at just that. So bolus feeding, the reasons why bolus feeding may be considered beneficial is because it is a more normal way to manage the gut. So the gut is used to having feeding periods and fasting periods, and the gut has different motility patterns to reflect that. My concern, though, with regards to bolus feeding in intensive care patients is glucose management. So I really think that the studies need to be done before it's adopted, because you're going to get great variability in glucose and difficulty managing in glucose if you bolus feed. So that's something just to be aware of if it's something that you're considering adopting. I think we should wait until the British trial is finished to see whether it is actually beneficial and see whether there was any real problems with glucose management before it's adopted widely.
The question is, how early should protein be added into the feeds? Should you start it right at day one or wait for a few days? And how about trace elements in enteral feeding? Any specific doses?
So, so I think that protein should be part of your feeding right from the start. So it's so feed formulae are balanced, so they tend to provide energy by a mixture of carbohydrate, protein, and lipid. And so I think protein should be part of your feeding strategy right from the start. There's no evidence to suggest that you should vary the amount of protein that you give early or late. There is a thought, particularly in the European literature, that you should try and match the sort of ebb and flow of the metabolic response to critical illness with calories. So maybe restrict calories early on, then give more calories later. but that is really an hypothesis rather than a proven fact. So with regards to trace elements, I don't think we really know whether you need additional trace elements during enteral feeding. So I believe the feed formulae have got trace elements added, and as far as we know, they are thought to be adequate. The at-risk group there, both actually for amino acids and trace elements, is dialysis. But really that is, again, a sort of unknown area, whether we do have to supplement that group with additional supplies to make up for their losses during the dialysis. That's something that we can hypothesize about, and we don't really know. There's a lot of unknowns, a lot of questions.
Just a question about using indirect calorimetry, really. Quite a few of the ICUs in Singapore, we've gotten it the last few years, and we really struggle. Do we feed to 100% in the initial phase, or do we just feed up to 50% based on a few of the recently published studies on sepsis and things like that?
Yeah. So I'm going to address calorie delivery tomorrow, but to answer the question, so the guidelines suggest that you should try and feed according to indirect calorimetry if you have that. My view on indirect calorimetry is it's a difficult technique. So to really use it properly to guide your feeding, you would have to do it every day, because the energy expenditure changes in our patients from day to day. So if you measure your energy expenditure on, say, day 1 or 2, it's going to be different from what it will be on day 5. So that makes it difficult. Also, there's lots of situations where indirect calorimetry is inaccurate. So for example, if the patient's receiving more than 60% of oxygen, also you should paralyze your patient. So there's lots of difficulties with its use, which makes me think it's not a particularly useful tool for day-to-day guidance for energy delivery. However, if you've got it and you're prepared to use it, then it is according to recommendations to feed according to the energy expenditure. Having said that, there are, as you were alluding to, there are trials which now suggest that feeding less than 100% of goal is safe. And so what I tend to suggest is that you aim to feed goal rate, which is around about 2,000 calories a day, or 100% according to your indirect calorimetry. And then if you only achieve 60 to 80%, which is what most people achieve, then maybe that doesn't matter. And so you don't need to push too hard to push up to 100% of feeding. That's my interpretation of the data at the moment. So we are doing a large study in Australia trying to answer this question once and for all. So we're doing the target trial, where we're randomizing patients to receive either 60 or 100% of their nutritional goals, and looking at survival. So hopefully next year we will have a final answer to that question.
Thank you. Just one last question is, in patients with septic shock on high-dose vasopressors, how do we optimize enteral feed delivery and prevent malabsorption? Any practical tips?
Yes, so some people are afraid of feeding patients who have got shock, who've got a vasopressor requirement, but the data don't support that. So it is safe to feed patients with shock. I've already shown you that gut blood flow, if anything, is increased in ICU patients. So you can still feed patients, you can still feed according to goal. So we've done some work on that, but other centres have done work on that as well. It's safe to feed patients with shock.
Right. But do you start them on prokinetics quite early, or?
Only if they have evidence of slow gastric emptying, as in large gastric residual volumes. So we don't use preemptive prokinetics. So we only wait. So I think you're perhaps alluding to the fact that the use of vasopressors themselves can slow gastric emptying, but we don't use preemptive prokinetics. We wait for evidence of slow gastric emptying before we start the prokinetics. One of the reasons for doing that is that patients become tolerant to the effect of the prokinetic. So you only have a certain number of days before the prokinetic stops working. So we reserve the use of prokinetics for when the patient really needs it. we initiate prokinetics, and then we give it for a few days, and then we stop it and see what happens. And if they still have large gastric residual volumes, we'll restart it again.
Do you use opioid antagonists enterally at all?
What was it?
Opioid antagonists like naloxone or
So I use that very occasionally when all other things have failed. I would more often try and put a small intestinal feeding tube in. So what we tend to do is use the combination of erythromycin and metoclopramide, and if that fails, go to small intestinal feeding tube. But using an opiate antagonist is an alternative and can also be considered. Naloxone is difficult to use because of the volume you need and the expense.
Just a question from the audience again is, how do you calculate nutritional requirements of patients on ECMO? I've never thought about this before.
Yeah, it's a good question. I don't know the answer to that. I think there is a dietitian who's doing some work on that in Melbourne, and I don't know the answer to that. I would just feed them. We just feed them normally.
Yes.
Yeah.
Okay. Any other questions from the audience? No.
Is it? Yeah. Thank you for your marvelous lecture. I would just like to have you comment on the issue of bacterial translocation, whether early feeding diminishes bacterial translocation in sepsis. Bacterial translocation in sepsis.
Bacterial translocation
in sepsis.
Yes.
Bacterial translocation, did you say?
Translocation.
Translocation,
Right.
yeah.
Whether not feeding the patient would predispose the patient to early translocation of bacteria from.
Would feeding a patient in sepsis predispose them to bacterial translocation?
Yeah.
No, it's the other way around.
Right.
Early feeding during sepsis help prevent bacterial translocation.
So we certainly believe so. Having said that, most of the data about bacterial translocation comes from animal studies, not from humans. But having said that, that is one of the reasons why we like to feed early, is to try and prevent bacterial translocation and the fueling and refueling of the septic episode. So yes, so even if we're having trouble with feeding, and even if we have to reduce the rate, which we try not to do, we will always keep some feeding going, even at a very low rate, even at 20 mils an hour. So that is given for a number of reasons, one of which is prevention of bacterial translocation, but also to maintain gut integrity. So I showed you the data on the small intestinal mucosal function and how that worsens with fasting. So we really try and avoid any sort of fasting episodes. The permissive underfeeding data suggests that maybe it's safe to underfeed patients, but you shouldn't fast patients.
There's a question on using gastric ultrasound in guiding GRVs. Any comments?
So we've tried using gastric ultrasound to measure gastric emptying. It's a really difficult technique, but if you become adept at it, then I think it could be useful. The trouble with measuring gastric volume in that way is it's very observer dependent. And we had a visiting chap from Norway who was an expert, and even he couldn't really routinely and regularly measure gastric volumes with that technique. But I suppose if you're just using it qualitatively to measure gastric residual volumes, then it may be useful, but it would really depend on your expertise, your own personal expertise.
There's a question over there.
Thank you, Dr. Chapman. My question is about, we know that there is a problem with the motility as well as absorption in the gut and critical illness, but how severe is the problem of assimilation of nutrients which has been delivered into the body? Because most of the trials don't even look into that. And this has an implication because if you are feeding someone when they're really unwell, despite us putting all the nutrients into the body, or even when you put it parenterally into the bloodstream, if it doesn't get assimilated, then it's going to probably cause more problems. Like, is the way to look at the data from TPN causing a bit of harm, like very aggressive TPN, it causes hyperglycemia. the nutrient is not getting absorbed, you got fatty liver, all those problems. So are we missing the boat by concentrating on things we can do, like looking at just the motility and absorption? And where do we stand on our view on assimilation of nutrients delivered in critical illness? And if that's the case, do you classify or like to subclassify patients of intensive care into the acutely unwell state versus the recovery phase where you would like to feed them to minimize the chances of ongoing catabolism and muscle wasting? Thank you.
Yes, I think you're talking about the dangers of feeding patients who are very sick and the changes in nutritional requirements over time. Yeah, so look, that's an interesting concept which needs further investigation in nutrition and ICU patients. But at the moment, there isn't any real evidence. It's a suggestion which has come out of Belgium based on their early or late initiation of TPN study. So I think we just need to be careful not to over-analyse, over-interpret that at the moment. But there's certainly a hypothesis, a suggestion that maybe our patients do have different nutritional requirements over time. And exactly how that's going to play out, we don't know. That will require fairly complex, complicated study to work that out. So at the moment, there is no evidence to support limiting calorie delivery early and giving more late. It's a hypothesis only.
But if you look at the general population, you fall sick, the first thing you do is probably cut down on your intake, isn't it? That's what the normal physiological response is. Or if you're going for a run like a marathon, the last thing you want to have is a big meal or meet your usual requirements of things. So it's a way we look at the data. We're like, if you just concentrate on the ICU data, we can easily say there's no data to support that hypothesis. But if you look at the general population or the way normal physiology works, there is a trend to believe that may be the case too.
Yeah, so that's true, but there's also the fact that you're dealing with patients who leave intensive care very wasted, cachectic. They take months or years to recover full functional recovery, and we know that their muscle mass is reduced and that is related to muscle function. So there's also a lot of reason to believe that improving nutritional delivery may improve outcomes. The problem is that we don't have a lot of proof either way at the moment. So you can make these sort of teleological arguments, but we really don't have the evidence yet.
Thank you.
Hopefully the target study will help.
Thank you. Just one last question. What's your view on long QT and prokinetics? And do you use, in patients with long QT on the ECG, and prokinetics?
What was the first part of the question?
Sorry. So basically, in patients with long QT syndrome or prolonged QT on the ECG, what prokinetics do you use?
Yeah. So the question is about long QTC, and the reason that we're asking that is because erythromycin, which we commonly use as a prokinetic, is associated with prolonging QTC interval. Now, the dose of erythromycin that we use is very tiny. So we have shown in studies, so we've done some dose studies on erythromycin and its effect on gastric emptying in the ICU population. And we found that a dose as low as 100 milligrams is effective in accelerating gastric emptying. So in our experience, and we haven't quantified it in the study, but in our experience, we have not seen any problems. We don't expect to see any problems with either prolonged QTC or cardiac arrhythmias with that dose.
Right.
So we've used that dose even in patients with renal impairment. So the only time I've ever seen a problem with erythromycin and cardiac arrhythmias was in a patient who was getting massive doses. They were on dialysis and they had it for Legionella, and that's the only time I've ever seen a problem with erythromycin. But sorry, that's very anecdotal, but so we don't worry about it because of the low dose.
Okay. Are there any other alternatives other than erythromycin or metoclopramide?
So there are some new prokinetic agents which are under investigation. So there is a new motility agonist, so that works in a similar way to erythromycin. There's also ghrelin agonist. So hopefully there will be some new agents in the future. But apart from opiate antagonists and metoclopramide, erythromycin, there's domperidone is used in Europe. It's not so used in Australia. So apart from those agents, there's not really much out there at the moment.